Excellent session by Joseph. This is more about thinking biases and diagnosis. So we started off a couple of weeks ago on sensitivity, specificity, basic part of diagnosis. We also did ROC curves. We also did systematic reviews of diagnosis. We also did health technology assessment. Now we have done AI in diagnosis. So we're trying to cover all the diagnosis. I think Vineet is not here, but he had also done on reliability statistics and the use of that. So this is an extension of that. And today we have done STAR-D AI checklist. And again, just to say that the STAR-D checklist is meant is when you are publishing a study of diagnosis to make sure that you have published all the aspects which people will require when reading it. The CASP checklist is for reading somebody else's published work. So the STAR-D checklist is useful for somebody who's planning a study and when they're publishing it. But we used that today like a critical appraisal tool, but it's actually more for somebody who's planning a diagnostic study involving AI, then what should you do? So that's that. Anyway, today's the reminder of, or the second, this is a separate talk actually, cognitive biases. So this is a common word used. Oops, sorry. When you hear hooves, think of horses, not zebras. So if you think about errors in diagnosis, oops, sorry. When we imagine how work will be, a patient will come to the OPD or outpatient department or emergency, and they'll have history and physical. We'll make a differential diagnosis. We'll order some tests, and then we'll give the appropriate treatment, and the patient will get better, and the patient's outcome will be good. Somewhere along the way, we imagine that if the history of physical or differential diagnosis is wrong, wrong test, wrong medication will result in failure, and then there'll be an unacceptable outcome. And this is also called the safety one thinking. And this Professor Eric Holnagel, maybe I'm not pronouncing that right, but he has talked about two kinds of thinking when making diagnostic errors or thinking about errors in diagnosis. So this is called safety one, where we think that something went wrong. But there's another view of looking at it. It's called the safety two approach, where you think that everyday work happens. You plan history, physical, and you plan the differential diagnosis, and you plan treatment, investigation and treatment, and things go right and you're happy. But the same everyday performance, which is already quite different from what you imagine, maybe there's no senior doctor that particular day to discuss. Maybe the differential diagnosis was wrong, and maybe the treatment was wrong, but still the patient got better. The same time, the same thing happened, but some small thing went different, because the performance again is variable from what you plan. The senior doctor wasn't there. You had a wrong diagnosis and a wrong treatment. But for that, there was an unacceptable outcome. So the failure is actually part of the everyday performance. It's not that when things go right, we say everything was right, or when things go wrong, everything was unacceptable. We have to look and see what happened exactly when this unacceptable outcome happened. This is called the safety two approach. So we'll talk about that later on some other day, but just to think that actually what we plan every day is quite different from the ideal which somebody would have imagined a workflow. And when things go right, it may not be because we made everything right, but it just happened to go right. And if one small link on the chain went wrong, it might have been an unacceptable outcome. This is called safety two approach. This is a very famous paper which everyone quotes when they talk about cognitive bias. This Institute of Medicine is like a very famous institute in the US which makes guidelines and talks about the future of health. And they made a famous article in 2000 which was called "To Err is Human," and thinking about errors of various ways in which patients come healthy to hospital but leave unhealthier because of errors in our healthcare process. So it's called the famous article "To Err is Human." One of the things they said that most people will have one diagnostic error in their lifetime. Sometimes that error can lead to devastating consequences. And 30% of the adverse events in a hospital are failure of the diagnostic process. I mean, somewhere along the way, we didn't make the right diagnosis. But there are many factors which can lead to this diagnostic process failing. One of them is cognitive bias, which is thinking bias. And it's an inherent clinical problem because diagnosis is uncertain. There's no diagnosis which is just staring at you in the face. And increasingly, patients are quite complex and diseases are quite complex, right? So to err is human is a real fact. This is 2001 and 2000, but this is a more recent paper, systematic review of diagnostic errors in a hospital setting, and they found it's only 0.7%. So it's not a huge problem, otherwise patients would be coming to hospital. So that is a recent systematic review. Then another person looked at the prevalence of diagnostic errors among people who are readmitted within 1 week. So patients are readmitted within 1 week of discharge. That means something went wrong with the discharge process. And they wanted to know what percentage of the readmission was because of diagnostic error in the first visit. That was 5.6%. So just to give a perspective that is not terrible going, but there is a problem of diagnostic errors. Now, this person, Laura Swan, has written a lot of articles about cognitive thinking, and they're just an overview of this. So, patients initially are quite healthy. Then there's some biochemical or physiological or genetic change which precedes disease. Then you are pre-symptomatic before you have symptoms. At this stage, like Anna talked last week about screening, this is the time we pick up screening. And she talked about two biases, lead time, lag time bias. And if you get too much of that, you're over diagnosing people, unnecessarily diagnosing people who would not have benefited from the diagnosis or the treatment after that. Then they become symptomatic and then they're diagnosed by new tests and potentially diagnosable. Here you can have delayed diagnosis because patient came late. It's a complex presentation. The doctor missed it. Somebody decided to watchful waiting, which will actually turn out to be a bad idea for that particular patient. And waiting for a definite diagnosis, and then the treatment wouldn't have changed even if the diagnosis was there or not. And few people would have correct and timely diagnosis. So even if the patient came symptomatic, there's a possibility of incorrect or delayed diagnosis. So all these lead to preventable harm to a patient. Sometimes it may not lead to harm also. So this is just to put the whole diagnostic process in one picture. This is actually what may happen in underlying diagnosis. So what are the general principles to improve the diagnostic process? One is content specific feedback. So every time we review a chart and we say, okay, look, this patient with cough and fever, you should have thought of pneumonia. It was not just some viral URI. You missed the diagnosis. The second one is to practice many examples. And the typical example, if you look at radiology, they look at thousands of chest x-rays and every time they become better and better and better, hundreds of pneumonia. Then the 101st pneumonia, they're very good at picking it up. The last one is now increasingly use AI to help you with some tools. Maybe a little overhyped at the moment, but increasingly AI may help. As we learned from Joseph's example, it didn't help too much, but there may be instances where the AI can help you. I'm not going to go into this a lot, but there is a taxonomy of diagnostic errors. It's called DEAR, Diagnostic Error Evaluation and Research Taxonomy. We won't go through the whole DEAR taxonomy, but basically, was there an error in history, physical exam, maybe the prior documentation, you missed some previous document of some test which could have helped you make the diagnosis. You missed some red flags. The patient had pain radiating to the back, but you missed that history and you missed somebody chest pain and you said this is non-cardiac, it turned out to be an aortic rupture. Incomplete or incorrect clinical information, some diagnostic evaluation. So like this, there are 13 points and you mark each of them on a Likert scale 1 to 7 as to where you think the error happened. This DEAR category then gets linked into 7 headings. Access, maybe the patient was delayed access to care, somebody from a tribal area or a hilly area took a long time to come down, or the patient didn't have money or denied access to care. History, physical, lab tests, hypothesis generation, assessment, some referral was delayed or the follow-up was delayed. So this DEAR criteria can be then put into this one of these 7 or many of these 7 areas. Another way of looking at diagnostic error is called model of unsafe acts. There could be an intended action or unintended action which could have led to some diagnostic problem. The unintended action, a mistake occurred if the plan is performed as intended, but the plan was not adequate to reach an outcome that was planned. So intended action could be a mistake. There was a good rule. Anybody who has uh, Ottawa ankle rule for fractures, but you didn't use it on the right patient and you missed somebody with fracture. Or application of a bad rule of thumb, everybody with this has this. But that's not the situation where it should have been used. Or knowledge, your knowledge was inadequate or you had some wrong knowledge which made a mistake. Violation is not some malignant intent, but that is there's a protocol and you didn't follow it correctly. The most common reason for protocol violation is time. There was no time, so I just did everything fast, fast. Usually you get away with it, but the problem happens when something goes wrong. So these are errors of intended action. The second one is errors of unintended action, which are called lapses and slips. Slips occurs when the correct action is executed poorly. Okay, there somebody came and started talking to you when you're doing some procedure. You forgot to do a test. You ordered the wrong test, or the timing went wrong. Lapses are memory. You forgot what you were planning to do. You forgot some step in the diagnostic procedure. So these are the other causes. Now I'm going to talk. That was all just a little bit more about cognitive thinking. But now I'm going to tell us how to overcome these cognitive thinking. And this is a nice paper uh, based by this Nicola Cunningham in the journal Diagnostics. It was published last year. So, what are these idioms? For example, up in the air doesn't mean that somebody is floating in the air. It just means you're undecided. So that is what is an idiom. And it's usually used because it's simple and memorable. We don't forget an idiom. And it helps to bridge the gap between a concept and knowledge. So it's an idea so the way I'm going to address cognitive bias is to use that paper by Nicola Cunningham. And what idiom comes to your mind? But that doesn't mean it's literally, I know some guys are throwing cats and dogs off the roof, but that is different. So now, opposite attract, birds of a feather flock together. So there are different types of idioms. So you should be careful about the use of idiom also. Should not use the wrong idiom. So increased use of idioms apparently trigger the inferior frontal gyrus and amygdala, and then that leads to more of cognitive engagement. So when you use an idiom, people start thinking, hey, there's some story going on here. So anyway, for those who like anatomy, that's the inferior frontal gyrus and that is the amygdala. Uh, and it triggers more emotional responses in the brain. And there's a shortcut to meaning. The moment I say it's raining cats and dogs, man, it's raining like anything. And it makes it more insightful and memorable. So we're going to go through about 15 cognitive biases. Uh, and I want to make it as interactive as possible, anybody online also. So we'll start with the interns. Can any of you think what is an affective bias? This is not no stats here. Zero stats class. Yeah, anybody? Serious illness. Okay, the thought is there's somebody close to you, they can't have a serious illness. So it's usually about the opposite. Somebody is irritated, you're irritated with, every time they keep coming up and then they're mostly anxious. And then they come up again and they're like, oh, this man again is anxious, or this lady is again anxious. This is anxiety, and you give some SSRI or amitriptyline and send them home. Actually, the patient had a large pleural effusion. So usually it happens the other way. There's affective biases when somebody don't like. So emotions influence thinking. It could be positive, like my friend could not be having a serious disease, but more often it is like this chap is just nothing. Just send them home quickly. So it's affected by our psychological, social, cognitive, cultural, or biological factors. So in the villages we say "Kai kaal isikkudu" in Tamil, which in English translate to body pain. Oh, one more body pain. Just give some vitamin and send them home. So that's a little bit of a problem. The related idiom is leading with your heart, not your head. You immediately think, this is what it is. So instead of using your brain, you're thinking with your heart. So what can we do to counteract this? Be careful of your own emotional state. This relates to your emotions. You're irritated that day, okay, finish everything quickly. So be careful of your own emotions. So think before you act. So before you diagnose somebody, just think like, hey, today how am I feeling? It's not how the patient feels. How do I feel at that particular moment? So think before you act. So channel your alternative. We try to be more compassionate with every patient, even if you are irritated by them. Try to be compassionate. So we're going to use the same kind of format for the next 15 examples. I'll ask you to guess what you think it is, then we'll go. Okay. Anybody anchoring bias? Any of the residents? Okay, just a guess. You can't, there's nothing to be wrong in this. Interns also can guess. Ah, that's a good thought. We're fixed in one diagnosis. But it's not the right answer. So somebody comes with weight loss and you're very happy. Oh, you followed my instruction. You started dieting and exercising. So you immediately think that what you did is the right answer. Relying heavily on the first few features of an initial diagnostic hypothesis and sticking with that despite something else. But the patient tells you, doctor, I'm having some loose motion, I'm having some tremor. No, no, you're doing well, you're dieting, you're exercising well. So, what is the anchoring bias? The first thought which came to your mind, he lost weight because he followed my instructions. So, you're anchored in that diagnosis. That bias is called anchoring bias. So, our brains commonly preference the first piece of information as a reference point. Everything subsequently, the tremor, the loose motion, is ignored. So this is also called digging in your heels. So that is like, for example, this is my diagnosis. So what are the subsequent thing comes after that? So we had a patient in private side. He came with fever and rash. And a lot of dengue patients were there. So we said, this is dengue. After the next day, the blood culture came enteric fever. Oh, but we thought like, no, 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 this is dengue. Everything will be that only. We told him in 3 days' time. Platelet count was no, no, it'll start coming down tomorrow. So we are a little bit. So be careful about digging in your heels. What can help? Be thorough. Consider differential diagnosis. Have you thought of all relevant negatives? So keeping an open mind is the answer to this particular problem of anchoring bias. So this is just to help us to think. Anchoring bias. Ascertainment bias. Any of the faculty? Or interns or PGs? Anybody? And you think of other answers. Something you recently read? Any of the Joseph? Ascertainment bias. Somebody is lying unconscious, got a syringe. I think this fellow has a drug overdose. Actually, the guy had hypoglycemia. But you find this unkempt fellow in the park with a needle and you think this is drug overdose. So making a decision based on prior expectation. So stereotyping. So this fellow, young fellow, hobo, lying in a park or lying unconscious roadside, must have been drunk, must have IV drug abuse. But actually he had a hypoglycemia. So we tend to categorize patients into groups based on our expectation. So this person must be having this kind of disease. So be careful of that. So ascertainment bias. So judging a book by its cover is a similar kind of point to that, right? So anyway, this is just a cartoon. I implore you, the jury, not to judge a book by its cover. So anyway, so that's just to say, don't judge. Oh, this guy must be, these kind of people must be having this kind of disease. The alternative to that is beware of your own stereotyping. Each of us is different, but we stereotype people into, oh, these kind of people behave like that. Be more empathetic, ask more questions. Looks can be deceiving. Is that the Taj Mahal? Somebody went for a holiday recently. Where is that? That's not Singapore. That is Las Vegas. Trump made a Taj Mahal tower. So just because somebody may think that's a real Taj Mahal, so that is not. So that is just to say looks can be deceiving. So everything which looks labeled Taj Mahal is not Taj Mahal. Okay. This interns have to say. What is authority bias? What do you guys feel? Be bold. Now I can tell you to be bold. Okay, so that's reasonably easy to do. So, for example, we'll blame the surgeons for this. Somebody did a neck surgery, there was an abscess, and then the patient is complaining of pain. And the surgeon says, there will be pain after neck surgery. But you worry, like, hey, the patient is having some stridor, maybe hematoma. No, no, don't worry. And then you go to sleep, and next morning, patient is unconscious and hypoxic. Well, that is a terrible tale to happen. So, tendency to assume that a more senior colleague is correct despite evidence to suggest otherwise. This is based on hierarchy, cultural norms. In CMC, we are generally less hierarchical than other places, but we are also hierarchical. You may think twice to question what I feel. So the answer to that or the related idiom is dancing to someone else's tune. Somebody else says this, then you better say that as well. Depends on the culture. So the answer to that is to recognize that everybody can make mistakes, even after a lot of experience, with a lot of gray hair and a big tummy. So remember that good teams pool their knowledge together. This is why actually it's good to go through the workstation together and then review all the history, physical. Hey, what else could it be? Could this be, that be? So always pool ideas together. The counter idiom, we're all cut from the same cloth. In other words, just because I'm more experienced or older doesn't mean I have some better differential or better idea than somebody else. So that is an easier one, authority bias. Okay, registrars. What is the availability bias? Hey, can I guess? What, Aaron? Faculty? Eva? When the test is available, it's more often. Read the story first. Making a diagnosis of hay fever in a patient with cough and nasal congestion on the basis that several patients presented similarly with hay fever. Availability is what's the most recent diagnosis. So during the COVID season, every cough and fever is COVID. During malaria season, every fever is malaria. During scrub typhus, every fever, whether the rash or not, or escar or not, is so that availability is like a RAM memory, like what was recently in your memory that comes up first. So be careful of that. The tendency to think of a diagnosis that comes to mind most easily based on recent or vivid experiences. So retrieval of facts and memories in our brain can occur spontaneously or through intentional effort. So this is also called front of the mind. Whatever's on your mind, you will think immediately. So the way to think about that is to think of differential diagnosis. You'll see that often one of the greatest solutions to all cognitive bias is to actively make differential diagnosis. Sometimes we do differential because the faculty is going to ask you, where is your differential diagnosis? So we just write it. But actually you must think. You must think more actively. And the counter idiom to this availability bias is rack your brain. So keep thinking, torture your mind to think, what else could this particular problem be? So this is called availability bias. Okay, this is for the faculty. Base rate neglect. Sounds not finished.
Diagnosing a rare disease.
Diagnosis of rare degrees. Base, ignoring the baseline risk. Okay, that it gives it away a bit. So this is overestimating the pretest probability of pulmonary embolism in a very low risk patient and ordering a complete workup because of the seriousness of the condition, despite how unlikely it is. So somebody who failed an exam came to emergency department with breathlessness. Oh, you are suffering from pulmonary embolism. That's very unlikely to a young person who had some anxiety provoking incident recently. So that is a bit like ignoring the base rate. In that young person with breathlessness, the pretest probability of pulmonary embolism is very low. That is called base rate, the pretest probability. Where do you get that pretest probability? It's basically from our intuition, clinical experience. So this is where that famous thing comes, hearing hooves, think of horses, thinking of zebras, not horses. So don't think of the rat. Some of us like that. I used to have some colleagues like seniors when I was a postgraduate senior, they'll come up with exotic diagnosis like, but it make the diagnosis. But be careful of that. Sometimes you get stuck in that thinking like everything is the rarest thing. So you're a perfectly healthy horse except for those stripes. I wouldn't worry about the stripes too much. We see this sometimes. You just need to diet and exercise. If that doesn't work, we'll try this antidepressant. So this is just from guy called Blogspot Theodore Woodward. So this is just humor. So be careful of this worry of labeling somebody. The second, how do you get over this problem of base case? We must be familiar with the prevalence of disease in our area. Like, for example, there was an argument about Joseph's case. How do we know the prevalence of cervical cancer in India? If we have no idea, every positive test is positive, every negative test is negative. There may be false positive, false negative, and we'll completely ignore that. So we must be familiar with that, including likelihood ratios. Other thing, counter idiom, common things are common. Anyway, this is just a joke. We have finally found something in common, mutual distrust. So this is just some humor about meetings in general. So that is base rate neglect. Okay, so this question I said you must know the baseline prevalence of disease, which Joseph used for his question. I was reading this up, and then recently somebody was questioning, should you use the incidence of disease happening at this time or the prevalence? Reba, what do you feel? Influenza? Diseases which are short incubation, short duration, and go away quickly. We should know the current incidence of that disease. Prevalence of this may not be influenza season, then prevalence will be zero. So we must be careful about that. So they are arguing that new cases over time is a better metric for differential diagnosis. It reflects the likelihood of disease of somebody with disease now. How likely is this new illness? Prevalence is existing plus new cases. So, for example, diabetes, duration is forever. Somebody dies of Ebola, then you'll never have anybody with incident because everybody died very quickly. Cure rates for something will high cure rate means prevalence becomes low. So you must think about this. So generally, this article is arguing that when you're trying to look at this pretest probability, look at the incidence of diseases, especially for diseases tend to last short, rather than prevalence of disease. Anyway, this is for everyone, importance of this base rate. I think the slide got once mixed up. So this is a prevalence of, there are 100 squares. What's the prevalence here? 3%. Those are the diseased people. Now the test has been introduced in this population. It 100%, it can detect all cases. The false positive rate is 5%. If false positive rate is 5%, what is the inverse of false positive from his class? He taught sensitivity, specificity, false positive, false negative. If the false positive rate is 5%, then specificity is 95%. So when you say a false positive rate of 5%, that means you're saying specificity is 95%. Sounds very good. So if you take 100 people, how many have disease actually? 3. But it will pick up 5 people extra as being positive or actually not diseased. So you don't know that. You're ordering the cervical AI test and you get 8 people who are positive by the cervical AI test. And you're very happy, oh, 95% specific. But what happened? Of the 8, how many actually have disease? 3. So 3 out of 8 is actually 37%. That's actually bad. That most people don't have disease who are positive. But you're treating everybody. Oh, this AI thing is positive. Let me do a biopsy. And then after biopsy, some of them will go for hysterectomy and all because they're not sure. Maybe positive, negative. Pathology is also confused. AI said it's positive. So you can see. Now, what about this prevalence here? 1%. So the prevalence here is 3%, but here prevalence is 1%. And you can imagine what's going to happen now. Because the same 5, so 1 out of 6. So only 1 out of 6 actually have disease. So this is called the base rate effect. So you need to know what is the prevalence, or if we go by what I've taught you just now, incidence for diseases which are of shorter duration. Okay, next back to our interns. Commission bias. Anybody? Let's see the interns now. Take a guess. Here's a commission. That's different. That's also true. In India, it happens. If you order a test, the doctor gets a kickback. That's different, but this is cognition, thinking, errors of thinking. Anybody else? Iba? Okay, that's possible. So commission bias is like omission and commission. I'd rather do something than not do something. So somebody comes with a sore throat, let me give antibiotic just in case it is bacterial. But the patient had running nose, sneezing, and a sore throat, this is most likely viral. But why do we always give antibiotics just in case it is bacterial? So we like to be towards doing something, action than inaction. We like to be doing something. So we have natural aversion to ambiguity. Okay, that means you say it's viral, you give the patient some paracetamol, you give them some antihistamine, come back in 2 days' time. If you're not better, the fever is worse, then we'll consider maybe a throat swab or antibiotic. But that ambiguity we don't like. So don't just stand there, do something. So, I mean, this is from a cartoon. All those with kids may not have seen this cartoon guy. So we like to do something. So the counteraction to that is consider the risk benefit. What happens if I just wait for 2 days? No, somebody's meningitis, we're not going to say, all right, let's wait for 2, 3 days and see what happens if we don't read. That's not a correct situation. But in somebody with a pharyngitis, nothing is going to happen for 2 days' time. So the opposite idiom to that is called the tincture of time. That means take time. Just wait for 2 days and see what happens. So in your brain, if somebody says commission bias tincture of time means like just wait. Let's see what happens. Wait for a few days. Be a bit patient. Okay, postgraduates, confirmation bias. Faculties, Anna.
But there are multiple other things lately that doesn't fit in, but because this type of
I'm positive you think. Okay, read the example first. Attribute a patient's backache to muscle sprain. So somebody comes, what do you do? I lifted heavy weight. My back is paining. Okay, you sprained your back or it's a disc. But you don't think that this is a postmenopausal lady with severe osteoporosis. It could be an osteoporotic compression fracture. So the first diagnosis is supported by your own thinking. You're anchoring in that thought at that moment. Yeah, obviously somebody lifted heavy weight, got a sprained back. You don't think, hey, could it be something else? So you're anchoring in the first thought which comes. In a sense, it is a sort of confirmation bias. Diagnostic momentum, confirmation bias are subsets of this. So the hammer sees the nail is like, okay, this is it. I know the diagnosis. Somebody fever and rash, I know this is it. This is, you're anchoring in the first one, not thinking of the second diagnosis. So these are slightly related kind of biases. It may sound familiar. So the hammer should tell the nail like, hello. And the nail is saying, wait, wait. And the, anyway. So that's the hammer sees the nail. So your first diagnosis, your, everything is confirmed on that. So the solution to that is what doesn't fit into this diagnosis. Maybe there's something in this lady, elderly lady, she's already had a fall and a fracture. Maybe this is not just a sprain. So the counter idiom, take the blinkers off. So this is usually horses when they race, they put the blinkers on them because the horse should not look left or right. So in a sense, it's taking off those blinkers. So have a wide view of all the possible differential diagnoses. Okay, diagnostic momentum, very similar to what we have talked so far. Anybody would like to hazard a guess? You want to keep your diagnosis and keep going down the same way. Well, this is actually what happens in our casualty. A CMO makes a diagnosis and then tells the intern who sees in casualty. The same diagnosis passes the PG. The PG says this must be the same diagnosis. And then the warded PG intern, everybody makes the same diagnosis. Because it's easy. Somebody has made a diagnosis, you came. Actually, more dangerous in the outpatient department. Suspected SLE, suspected rheumatoid. Then the next person says rheumatoid. Then the third person, the third visit says known case of rheumatoid or known case of SLE. So the suspected thing became the diagnosis and the treatment also becomes continuous same treatment. So somebody comes to the emergency department with abdominal pain and constipation. The Emmerich says there that this abdominal pain is because of constipation, and that abdominal pain because of constipation is handed down. That is called diagnostic momentum. So this occurs more openly when there's pressure to make a quick diagnosis and the early hypothesis is transformed into an accepted truth. This happens in hurry and especially during handover times that this is the likely diagnosis. And the idiom for the diagnostic momentum is it is written in stone. This is what the diagnosis. Don't tomorrow go around thinking what else can it be. So like I'm just made a picture of, cartoon of this caveman writing it in stone. This is what it is. So the initial label can come from a patient, healthcare worker, or their staff. Somebody can say this is a known case of asthma. Everything is related to that. So how do you get over this diagnostic momentum? Be very careful on handovers. For the intern, when taking from other intern, think again. Hey, I've not taken the history. Let me retake the history of the postgraduate or the faculty. Always keep thinking, should I retake the history and exam? Is there something that has been missed? There may be some new test which comes positive, but you ignore it saying, no, no, this is the known case of this. That new diagnostic test has no place to be positive. Think maybe it has a place to be positive. So the counter idiom, take it with a grain of salt. Grain of salt means everything somebody tells you like, hey, maybe it's not to be 100% gospel truth. This is just a cartoon. I don't know if you've read Dennis the Menace. That is his mother, Mrs. Mitchell. Here, mom, you said everything she says, take it with a grain of salt. So anyway, this is just some fun. Diagnostic momentum. Okay, we're coming towards the end of our talk. framing effect. There's a any of our interns. Excellent, excellent, excellent. So, how somebody tells you a story, you take that as the whole story. You don't see the entire story. An older person presents with breathlessness to the cardiac OPD, and you auscultate and you found a systolic murmur and aortic stenosis. So they say this is a cardiac OPD, you're likely to have aortic stenosis and you're admitted. I guess an old man had fallen down recently and has got a hemothorax. But you are framing the situation in a cardiac OPD, somebody the cardiac murmur, the breathlessness is framed as cardiac. So favoring a diagnosis according to how somebody describes the problem. So that's why sometimes in the short cases in exam, this is a cardiovascular short case. So you know that, okay, the breathlessness cannot be due to anemia, can't be pleural effusion because you're told. But in real life, people don't come labeled with diseases like that. But in our mind, we often frame people like that. So missing the elephant while studying his tail. So you're told only about the tail and you say that's the whole story, but actually you missed the elephant. I mean, there are various ways of telling the same story. So purposefully reframe the information. What am I missing? Am I missing some other story? Retake the history. This is where asking somebody else to have a second opinion works. Hey, is there something I should have been thinking? This is why nice when we're all sitting together and we start thinking, hey, what else could it be? Right? So step back and see the bigger picture. Anyway, this I used an elephant cartoon for this. Your problem is that you don't see the bigger pictures. Elephant is saying to the okay. Almost the end. Attribution error. Finish? Reba? Guess? Erin? Anna? The clue is in the images. Okay, read the example first, then you will get the thing. A patient is behaving aggressively with slurred speech. He is known to have schizophrenia and alcohol use disorder. So what do we say? The schizophrenic got drunk and is misbehaving. Or the schizophrenia is acting up. Actually, in fact, we later on found alcohol level is 0 and he had a cerebellar hemorrhage. So this is attribution. Tendency to attribute patient's behavior to their personality rather than circumstances. So over attribute behavior to person's personality. Drunken gait, alcoholic. Drunken gait could be so many things. So this is also the related idiom is seeing the actor without the stage. This is the actor on a stage, he may behave in a particular manner because that is the stage he's been told to act. But if you take out the stage, you may interpret it slightly differently. So be curious to ask about behavior. Imagine the situation from their perspective. Will the guy really be drunk in the middle of the morning and walking about in a hospital or in a school? No. So probably may not be alcohol related. So this is the counter idiom is walk a mile in their shoes. Just imagine from their perspective what would have actually been the story. So this is just a cartoon. Okay, I've walked a mile in my shoes. So I suppose you can judge me. Anyway, I don't suppose you could have kept my shoes. So anyway, this is just a cartoon. Like think a little more before labeling somebody very quickly. Attribution error. Okay, for the statistician, gambler's fallacy, young statisticians.
Based on the example, so like.
Yeah.
Suddenly like this, that is you are deciding it's not even the
Correct.
other thing seriously.
Yep. Anything else? Suppose you get 5 dice in a row. Are you likely to get one more dice in a row, or you think you will not get another 5 dice? Very unlikely. So the clinician sees a number of patients with inflamed joints which turn out to be septic arthritis. The next person he says, hey, how can we have 5 septic arthritis in a row? The 6th person must be reactive, must be rheumatoid, must be something else. You cannot be having. So when people gamble, they often do this. Oh, this 7 heads have come in a row. They're playing cricket, tossing that, I lost calling tails, let me call heads now. So that is a tendency to believe an event occurred more frequently in the past, it is less likely to occur in the future. Because we think it should be an average of heads and tails, average should be equal. I've got 5 heads in a row, the next one should be tails. There's no reason it should be tails. So that is called the gambler's fallacy. It's also related to call playing the odds. So be careful that we sometimes do the other way. This is a bias, the ulta way. I've got too many of this diagnosis. I don't think the next diagnosis could be that. So anyway, I don't know if you have seen this, the Suits, it's a famous serial on TV, and there's a hero is called Harvey Specter. He says, I don't play the odds, I play the man. Anyway, so maybe it's old man serial. So the counter to that is remember the principles of probability and randomness. Test the logic of diagnosis. So other counter, clear the ledger means like get rid of the previous thoughts about the 5 patients before and then restart. Who plays cricket here? JP, tell me the example in cricket. So good cricketers will be like this. Every time there's a tea break, lunch break, when they come back, they'll again take fresh guard, off stump, middle stump. So reframing your mind, get back again to the baseline risk of this new patient. Don't think the previous patient diagnosis is going to affect this person's diagnosis. Anyway, this is called the gambler's fallacy. Only 3 left. Hindsight bias. That's the PGs. Have you had death audit? Not yet. So my consultant tell me death audit should not be the death of the registrar. Because we'll audit all the deaths and say, like, this patient died because you missed this diagnosis. So what's the bias in that?
Next patient, you say you think all that.
Good thought. Anybody else? Hindsight bias is you missed a case, reviewing a case of mispresentation of sepsis, assuming that you would have made the diagnosis earlier. So I know that this person had sepsis and died. I'm reviewing the case. I think that this intern should have made the diagnosis on day 1. But I don't know what information they had on day 1. What was the clinical picture on day 1? So hindsight bias is being clever in retrospect. You should have made that, not me. Somebody else should have made the diagnosis earlier. They missed it. So this is more when you're doing audits of charts and looking at somebody else's errors. Be careful of this particular bias called hindsight bias. So this is also called hindsight. Vision in hindsight is 20/20, meaning perfect vision. In the back, we look back, everything should have been that way. So we exaggerate our own skills. I would have made this diagnosis on day 1. No, you would not have made the diagnosis on day 1. So this is called hindsight bias. So this is just a comedy, cartoon of hindsight. In hindsight, I should have worn a helmet, face mask, seat belt. So what can you do? Consider the time course of events. In that 10 minutes in the emergency department, when there were 7 other sick patients and there was only limited information, could the intern or postgraduate have made the diagnosis without any blood test? No. And the other way to think about it is you can't see around corners. What is happening next? You don't know. With the given information at that time, could they have made a diagnosis? If not, then you should not chastise somebody. Hindsight bias. Groupthink, very similar to what we have done earlier. So a person comes with leg ulcers, bed sore, delirious. You say sepsis, delirium. He's irritated. It's a violent delirium. Give some opioids. He'll calm down. The delirium gets worse. He's more violent. You increase the opioids, and suddenly he becomes unconscious. Nobody stopped to think that maybe it's the opioid which is adding to the delirium and getting worse. And instead of reducing the opioids, you increase the opioids. But somebody in the group thought about it, but didn't want to say because nobody else in the group is saying. So they thought, I must be wrong. If 6 people thought the same thing, how am I the 7th odd man? So this is similar to the other kinds of biases, the kind of premature closure at a group level. So there's also, idiom is running with the pack. So if everybody says one diagnosis, don't be afraid to say, I have a different diagnosis. So the cartoon I've kept here is this. I've seen this often, like, cows running in a herd and jumping off the cliff, and then they themselves know it's a herd thing. So the answer to that is an environment where people are happy to share their alternate views. I can see some of my faculty like, what has happened today? So admit uncertainty or go against the tide. So if everybody is swimming this way, don't be unhappy to swim against the tide. Omission bias. Okay, I did commission bias. So I'm going a bit fast. I'm not asking you all. Any of the interns want to hazard omission bias? There was commission. Omission is the opposite. So what would it be? So a patient comes with headache and fever, and you think this is most likely going to be tension headache. Why? Because if I suspect meningitis, now I have to do LP. Patient will start grumbling. I'm going to have backache. I post a LP headache. If I don't get, I have to call registrar. Let's just call it viral, or let's call fever, tension, give paracetamol. Please come back tomorrow. So you're not doing something for discomfort for you or the patient. They're not making a diagnosis. So it's not from a evil perspective, like I don't want to make a diagnosis, but is a convenience. So we want to simplify decisions. If I just give paracetamol, I'm happy, he's happy, everybody is happy. So there's also a related idiom is letting sleeping dogs lie. That is, don't unnecessarily start doing tests. You may find out something which you don't want. Just see what's happening. So this is omission bias. So the opposite of that is reflect on this. What if this is not a tension headache? What if this is really meningitis? How will I do? So for meningitis, you should not say go back with metacin and come back tomorrow. For a viral sore throat in bacterial, okay, you can say please come back tomorrow. There, tincture of time is useful. But if your diagnosis is very serious, then we should not use tincture of time idiom. Here it is nothing ventured, nothing gained. The opposite of omission bias. Like try and get up and do something. This looks like me. How to extricate yourself from the bean chair. My wife will be very amused by that. Okay, the last one, outcome bias in a prospective sense. So a lady comes with menorrhagia and tiredness, also has some few bruises. So we 99% will say this is anemia due to menorrhagia, just give some iron tablet and send them home. But that bruising didn't fit into the diagnosis. So tendency to favor a less severe diagnosis. If we had added bruisability, then we said, oh, there's low platelet count. This is bicytopenia. Bicytopenia could be a malignancy, hematology malignancy. But we favored the initial part, the lethargy and heavy menorrhagia, and said that is the most likely thing. So it's an outcome bias, wishful thinking. That's all it is. It is just menorrhagia. Give some hormones, give some iron, and everything will be fine. So this wishful thinking is like hoping that it's the less serious diagnosis than the more serious diagnosis. And the way to counteract that is to keep thinking about a second opinion. What else could it be? So dig deeper, get to the heart of the matter. Maybe there is something. So in OPD, one of the ways to keep writing at least the findings which don't fit in. These findings didn't fit into my diagnosis. The next person says that, oh, okay, rheumatoid arthritis, but this finding didn't fit in. So that is a thought process is still there. This is outcome bias in a retrospective manner. Okay, so we're doing a chart audit and I'm auditing your chart today, one of the interns. So your chart comes in, fever, cough, given paracetamol and antihistamine. So today evening I review your chart and I'm very happy. I said, yes, the intern has done a good job. The next day the patient comes with pneumonia and septic shock and dies. So Vignesh reviews the chart the next day and says, oh, this intern has made a terrible mistake. Because I'm viewing it now from success or failure. I'm viewing it, patient did well. As far as I reviewed your chart, the patient got paracetamol and seemed to have gone back happily. But the next day when the patient became worse, suddenly the previous day's decision appears to look bad. So this is called outcome bias in a retrospective sense. So if the patient did well, badly, we say the previous decision was bad. The patient did well, previous decision was good. So no harm, no foul is generally if everything went well, we think good. Remember I told you system 1 and system 2 thinking. As long as everything went well, very often things may be badly going on, but patient gets well. We miss that large chunk of patients who actually might have done badly. So no harm, no foul is not a good idea. So actually the counter idiom is not whether you'll win or lose, but how you play the game. So you must do things right. Then only you must see the outcome. But of course, it doesn't sound very fair always. When you lose, especially when someone tells you it doesn't matter if you win or lose, it sucks a bit, but still. The last one, premature closure, similar. Somebody came with an ankle fracture after falling off the ladder. Okay, ankle fracture, healed the fracture, but you didn't ask whether there was head injury and examine the head. So you're quickly not looking if there's something else which is related but not to that immediate. Nowadays in casualty, people are careful. There's a trauma list. You have to go through the whole thing, CT brain for ankle fracture. You think, what is this? But actually, it's a good idea. So we are hardwired to spot a pattern and it's helpful. Okay, this is the diagnosis and we are finished. So don't jump to conclusions. So that is an important thing. Don't make a quick diagnosis. Think of what else could be there. Okay, I'm being silly now, really. So look before you leap. Be careful. There may be something else. So that's anyway the frog is jumping into the. Okay. Hey, I have one more. Representative. Did I finish this? Representative bias? No? Okay. So representative bias is thoracic aortic dissection should have pain radiating to the back. That's what we are taught. So somebody comes with backache or some chest pain with not radiating to the back. We may say this cannot be aortic dissection. But not all patients have got classical clinical findings. So that is the representative bias. So we must be a bit careful about this prototype symptoms which if missed. For example, many women won't have angina, but breathlessness is angina equivalent. That's why many women are missed MI stroke because, oh, they do not have typical chest pain. So that's something to be careful about. So sticking to the script. So, we are always saying this person didn't have severe backache, that's why I didn't think of this. Be careful. So the counter idiom is not everything is textbook. There may be something lurking underneath, which this is what it is. Oh, I made a discovery. In fact, there may be something sinister hiding underneath, which you have missed because you're already looking for classical symptoms, whereas the atypical symptoms, which are not according to script meaning what written in a textbook, is hidden there. Oi. Okay. Stethoscope bias. Somebody comes with diabetic neuropathy, you give amitriptyline, not giving better, you give SSRI, not getting better, you send them to PMR, and the PMR doctor examines and says, oh, there's a missing pulse in the leg. But you went on for 6 months with the SSRI because you thought, this is a diabetic neuropathy, not getting better with amitriptyline, let me increase to SSRI, and only somebody incidentally decided that, let me check the pulse. So that is a status quo. Yeah, this is what the diagnosis is. And not getting better is because the medicine is not there, the dose is not adequate. That's called a status quo bias. So related to if it's not broke, don't fix it. Like if somebody's already made a diagnosis in OPD, let me just continue the same treatment. Oh, I think Thambu saw this patient, let me just continue same. But something is not fitting inside. No, it's fine. Just continue. That's the status quo bias. So new thinking, out with the old, in with the new. 2026. Let's make new differential diagnosis. Man. Sunk cost fallacy. This is a nice one. It's like a joke. Sometimes if you go to some places to barber to have a haircut, and barber is busy and there's another barber shop nearby. You know this joke? Barber only cut half your hair and then go to the next person. Why? Because you can't leave now because half your hair is already cut. So you cannot leave from there. So you're stuck there. You already spent so much on this. Now you're not going to again go and pay money and get another haircut. So you're forced to get a horrible haircut. So, for example, somebody has got small lesions in the brain. And often when you read this MKSAP, they're full of multiple sclerosis. So you saw this is multiple sclerosis and you start immunotherapy. After 2 years of very costly immunotherapy, these lesions are increasing. But you don't want to think that, hey, maybe this is small metastasis which I missed. You have spent large amount of money on MRI with special features. You have put a lot of money into treatment. So this is also called the sunk fallacy cost. You put a lot of money. You spent a lot of money on a diagnosis or stock market. You invest in the stock market, you lose money. And then after some time you think, let me invest in another stock market and then win some more money. And then you keep on losing. So that's called the sunk fallacy cost. You just think success is around the corner. Let me even borrow money and then invest in the next one. So cut your losses. The moment you think your diagnosis is not working, don't be scared to stop and think, okay, maybe I made a mistake. I was going the wrong direction. Let me rethink my direction and come back. Okay, triage queuing is, okay. Somebody comes to the gastro department admitted with a GI bleed, has chest pain. What will the gastro doctor think? I'm not saying gastro doctors will think that. I'm just making a joke. They'll probably think that this person has esophageal spasm. Let us give some proton pump inhibitor. Let's give some mucane gel. When the person may actually have a secondary myocardial infarction. So what is triage queuing is, you link people with their location. Like they say, location is everything. Like if you want to buy a property, location is everything. So you look at a Russian fellow from movies, somebody looks and speaks Igor and makes some, looks like emotionless fellow and shoots everybody. Or similar thing to that, people from India is a sweatshop for the people in US. So that's where all our shirts come from, underwears come from. or from evil communists appear. That is called triage queuing. You look at people and say, oh, you're most likely from that place, you're likely to behave. When we read papers from some countries, we say, oh, those people must be all fraud papers. So that's a triage queuing. So always look through a different lens. Maybe if you look through a different lens, you'll have some different viewpoints about life in general. So this is anyway. Okay. There now, in the interest of time, I had some people call these other kind of biases, but last, what is the opposite of Occam's razor? Anybody? Occam's razor is every symptom should be put into one disease, symptom, sign together. Yeah. So another guy called Hickam, he said that a patient can have as many diagnoses as he wants. Of course, there were some bad words thrown into that statement. But it's just, don't try to always squeeze everything into one diagnosis. A person may have as many diagnoses as they want. So how do you de-bias yourself? First is these kind of sessions can help us to de-bias ourselves. At least we are aware of these biases. This is a book which I think Tina also gave me a book on by Daniel Kahneman, I think, Thinking Slow. So think slow. Don't be in a hurry to make a diagnosis. Thinking about your own thinking is called metacognition. So now you become a little bit aware of your own self. How do I think? How do you think is called metacognition. Have a checklist. See, in surgery now they have the surgical checklist. I think one Indian author made a book on checklist. I don't know what his name. So he made before surgery 5 checklists. But in medicine it's a bit difficult. But in surgical specialties where things are little fixed, checklists will help you to make a diagnosis. Teaching statistical principles like we do every Saturday, some people have found that some people are able to use it during the stats session. But in real life, they don't use base case effect. They don't think of false positive, false negative rate. Every positive becomes positive, every negative becomes negative. Novel methods, one is a group of experts. So when you have different difficult diagnoses, get a group of people together. Guys, these are the history, physical. Anybody want to retake history, physical, differential diagnosis, change the test. Is another way of doing it. Video games, instead of MKSAP where we look at history, physical, tell you differential, we can tell people video games. So this is a video game where you have to identify the terror suspect. There are 1,000 people. Always, when the terrorists will say the police missed the terrorist. How did they miss? So you give them a video game. This is the person, the location, and the arms. So you have different people, and then the policeman is supposed to identify from the video game who is a terrorist and then go and capture that fellow. There may be many people who look like terrorists. The location may think they may be having something which appears to be a weapon, but the guess is whom do you think is a terrorist? So in the end of the game, there are 2 types of errors one could do. One is dispositional cues. That means cues about the person. Remember I told you may like a person and say, or you may dislike a person and make a diagnosis. Positional cues are about the person. Situational cues is where they are, environment. Guy is found unconscious outside a bar. He must be drunk. We won't think of hypoglycemia. So based on that, you can make answers to your assessment. So video games are another way of teaching people about diagnostic errors. Okay, there's something called a 2D approach, which I just want to end with this. We are often taught to think about systems, brain, heart, lungs, liver, kidney. But then we also think about vascular, infection, neoplasm, degenerative, toxic, congenital, autoimmune, irritable bowel. So we have to marry both of these together, multi-system with multiple processes. So some people will say that is called 2D thinking. We're not putting only system-wise plus different pathologies. Can we link up different pathologies with different, could be many systems that are involved. Anyway, this is called the 2D approach. The last study, meta-analysis, because we are doing systematic reviews commonly. So this Laura's one has done a meta-analysis of how to avoid errors, and there are different tools. The tools she looked at were checklists, computer decision support. So in OPD, you type a symptoms, and the differential diagnosis will appear. And then it'll tell you these are the likely tests. So you can ignore all that, but the computer is trying to aid you. Then you have instructional tests, red flags. Elderly man with backache. Hello, this may not be a red flag pickup. Or guided reflection. That means you're forced to rethink about your diagnosis. So these were the interventions that people have done in randomized controlled studies. And this is the forest plot. We don't have time to look at the forest plot, except to say the summary favors an intervention. So interventions to prevent diagnostic cognitive errors do work. There's some amount of heterogeneity, but the point estimate is 0.7 in favor of intervention. Now that we learned grade in great detail, unfortunately, the risk of bias overall was quite high. So there is some evidence that doing something to prevent diagnostic errors. So slow down, you move too fast. Be aware of your base rate for differentials. Consider what data is truly relevant. Seek alternative diagnosis. Ask questions that disprove your hypothesis. Don't only go with what proves your hypothesis. And remember, you're often wrong. We don't like that, to think that we may be wrong. Okay, this session went a bit longer than I thought, so I shall end here.